Hello friends, today we are going to discuss how will you differentiate whether this is a case of multiple sclerosis or aquaporin 4 IgG or MOG. These three entities they resemble each other, and sometimes you encounter some cases in which it become very difficult whether this is MS, whether it is aquaporin 4 or MOG. Now, some points of differentiation. Number one is the antecedent infection or immunization. We have sometimes we get a prodromal uh, history of prodrome of any viral illness in case of patients with MOB, which is rare in both of these entities. Secondly, age is affected. In MS and aquaporin, any age can be affected, but in MOG, it can be seen in children and young adult. Now, sex ratio, females are more commonly affected than males in MS and aquaporin, but in MOG, this ratio become equals. So, males are more predominantly uh, in male to female it is 1.5 is to 1, though females are slightly preponderant, but males they have increased risk of having MOG. Now, epidemiology, whites are more commonly affected in MS, whereas in aquaporin 4 IgG, it is a disease of African Americans, Afro Caribbeans, Asian population. Okay, now for MOG, geographic is unknown. And what are the most common for MS? We know it is myelitis, optic neuritis, brainstem cerebral episodes, myelopathy. For NMO, any combination of recurrent myelitis, we have the three core features. One is the recurrent myelitis, then we have optic neuritis, and then we have area postrema. These are the three main core features. And in MOG, it is most commonly the recurrent optic neuritis, ADAM, and the long segment myelitis, and relapsing optic neuritis is very common. Now, relapsing limiting course, it is seen in MS, whereas in NMOSC, it is typical relapsing, but there is usually no secondary progression. In MOG, it has a monophasic course or sometimes relapsing course, but there are no reports of secondary progression. Now, attack severity. MS attacks are mild to moderate, whereas severe disabling attacks are seen in aquaporin 4 and MOG. Now, recovery from attack is good in MS, but it is incomplete in NMO, and it is good in case of MOG. Now, CSF, if we want to see CSF, we can see that it is inflammatory in all. OCPs are more commonly seen in 85% cases in MS, whereas in aquaporin 4 it is seen in 30% of cases, and in MOG it is seen in less than 15% of cases. So OCPs can be present in MOG and NMO also. And we have blood biomarkers like aquaporin IgG for aquaporin 4 and MOG IgG for MOGAD disease. Now, brain MRI, typical multiple sclerotic lesions are ovoid, periventricular, Dawson fingers, juxtacortical, cortical, infratentorial, peripheral ring, open ring enhancing. Whereas in aquaporin 4, these MRI brain can be normal. But if it is a area postrema syndrome, then area postrema, peri third and fourth ventricle, splenium of the corpus callosum, pencil thin ependymal or cloud enhancement. And in MOG, MRI brain, you will see the atom-like picture of fluffy white matter, deep gray matter, diffuse confluent brainstem including cerebellar peduncles. Now, optic neuritis is a differentiating point. We know that in MS, it is mainly unilateral and it affects mainly the middle of the optic nerve. Whereas in NMO, it mainly affect it is bilateral and it mainly affect the posterior part of optic nerve including optic chiasma. Whereas in MOGAD, it is anterior, that is anterior optic pathway is involved, hence optic dysedema can be seen. In spine MRI, we usually get short segment myelitis in MS. Now, and periphery of the cord is involved. Whereas in NMO, we have the long segment myelitis. Short segment is seen in 15% of cases, and on axial view, central part of the cord is involved. And in MOG, we have the multiple lesions. We have long segment, longitudinally extensive transverse myelitis seen in 75% of cases and short in 25% of cases. most important point is that conus is involved in MOG. Okay, acute treatment we have IV pulse therapy, methylpred, or plasma exchange is rarely required. But is an NMO IV steroid, plasma exchange is often required. And in MOG, IV steroid plasma exchange, IVIG can be used in children. Now, maintenance therapy, we have a long list of therapy for the multiple sclerosis, whereas none is approved for NMO. But what are the things, what are the drugs which we give in maintenance? Azathioprine, mycophenolate, rituximab, eculizumab, tocilizumab, methotrexate. And for MOG, we have azathioprine, IVIG, mycophenolate, methotrexate, rituximab. Prognosis is majority patients they are ambulatory even after 20 years of age, whereas PROTAC related accumulation of disability seen in acoporin 4 and in most disability with first attack. Transient seropositivity, if it is present, it predicts the monophasic cause. And if it is persistently positive, there is high titers of MOG antibody, it predicts relapsing disease. Thank you.